Welcome to Bite Size Conversations. We are privileged to have Chad with us today. Chad is the manager of our EMS department, and he's going to give you a little history of EMS, some little things that are unique to us in the rural areas about EMS, and then I saw something up there about Andy. If you guys are out on Facebook, you've probably been seeing a little video series that we've been doing about an accident that happened in Henning. If you haven't seen it, I would go to the Astera website and make sure that you take a good look at that. And then after Chad's done, he's going to demo the Lucas with you guys. So you can see what happens and what happens if you go into a code. Right.
Thank you, Kim. All right. Yeah, as she mentioned about these videos, I don't know if this one's been circulating yet or not, so you might be getting a sneak peek on this one here. So we'll start off by just playing this.
I got to just do what I can to get to the point where someone's going to come find me. And I was just driving on my Ranger, and I was turning right onto a gravel road. The Ranger just slid. I probably just had too much speed making the turn, hit the gravel, slid, flipped over into a ditch. I was ejected from the Ranger. I literally remember being in the air when I was ejected from the Ranger. But then the Ranger came rolling down the side of the bank and then pinned on top of me is basically what happened. So for a period of probably 6, 7, 8 hours, I was just laying there. When they finally did get to me, like, things were getting a little gray. I don't know if I had another hour. I don't know if I had another half hour. Maybe I had more time than I thought.
So that morning, I remember it was graduation weekend, Memorial Day weekend. It was cold, kind of rainy, had been rainy, wet. All of a sudden, my active on my phone goes off, and I wasn't even on duty, and I remember looking at it going, oh, ATV rolled over, male trapped underneath. I go to my husband, who's also on Henning ambulance, and I'm like, hey, why don't we just go check it out? I know that if a person's pinned under a vehicle or something for a long time, again, toxins can build up and really cause some bad issues to happen, especially with the heart. And he goes, yeah, let's jump in. And arriving on scene, fire department was down in the ditch. Our ambulance crew that day, they were down in the ditch, and I just remember, hey, is that ATV still pinning him? And they said, nope, we've got it off. And I kind of knew we were in trouble, just knowing that all the toxins had been released. They were getting a C collar on you, getting you backboarded. And I just remember your legs were cherry red, and like your veins were black and purple. And I'm like, get him in the truck, we gotta go. And our fire police chief was awesome. He had already called for a Tri-County intercept and had air care coming. We just started, trying to work on getting all the cold clothing off. And I remember at that point, they had just said, you had been talking, and now you couldn't even answer like yes or no questions. And so I knew like things weren't looking good. We just got to get going, get you warm because it was cold.
So I was on duty and was the intercept paramedic for this. So opened up the back doors and hopped in. There's Chelsea assessing and doing her thing, and we had Andy on the stretcher, and it looked pretty tough. Okay, it was a pretty rough looking patient, and we were only on scene for about a minute. Right, this was one of the more critical calls I've had in 35 plus years of doing this. And off to the hospital we went, and we had a full trauma alert. Our ER staff was all ready. Helicopter came right to the hospital, to the helipad.
Once it dawned on me who it was, and a high school friend, and then I remember at one point just praying, I don't want to go to a friend's funeral. It was a huge team effort by everybody. It wasn't just Henning ambulance. It was Tri-County, it was the surgeons and the doctors. But every chance I see you, it's a miracle, because what medical numbers show, you shouldn't be here, but God had other plans. And just to be a part of that is, it's very fulfilling.
I did not have high hopes that day when we loaded you in the helicopter, and to see you walk across the street that's what I got into this for, right? And I'm really, really glad it worked out this way.
Absolutely. Thank you.
Yeah,
Yeah.
it worked out.
Once people started filling me in on the chain of events, who was there, maybe, things like that, then when you come back and see them around, in the community, it's like you see them in a different light. Like they can do things that save lives. And that's just, what makes the difference. Like,
Yeah, there's another part of that video we'll catch the end towards the end of this presentation, but very powerful story that Andy has there. We're grateful that we have a team here that put that together and is allowing us to share his story. And that is just one of many people that we touch in our communities. So I already kind of talked about my introduction. I'm the manager here. I've been with Astera for almost 11 years now. I've been in the manager position for 2.5, somewhere around that mark. Started as just a part-time job in EMS. I was an EMT. I worked once in a while, nights, weekends, kind of a thing, and then EMS kind of sunk its hooks into me, and I got hooked to it. So I'm here full-time now. I started out as full-time EMT, went to school, got my paramedic, and now we're back up here today as the manager. So a little bit about what we're going to do today. So like Kim said, I'm going to give you a little history on EMS. Different certification levels. There's a lot of confusion in EMS. We'll talk more on that. The current state of EMS, especially in the rural areas, the future, what it looks like for us, and share little fun facts as well. The end, we will be demonstrating the use of the Lucas device. That's a manual CPR device. So just so you can kind of see, if in case you haven't seen it out and about or any videos on it, we'll show you what it looks like up close and personal. History, so before the 60s, there wasn't really an EMS organization. It's just funeral homes would go and take people to the hospital once in a while. That became kind of more organized. So you called for help or somebody needed help to get to the hospital, a hearse showed up, and they're the ones that transported you. When I started out my career for small volunteer service, one of the senior EMTs there said, yeah, he said, he was on when we had a hearse in the service, and they used to call us oxygen transport specialists, because that's literally all we did. We put you on high flow oxygen, we threw you in the back of a hearse, and we drove like crazy to the hospital. So in the 70s, EMS was born. Yeah, the 911 system was implemented. There was some federal law that went into place for that. And that's when you started seeing the advancements. If you remember the old show Emergency, it's still aired every day if you want to catch it. But that's kind of where that stemmed from, is just bringing the knowledge or just shining a light on the EMS system and how important it is to have these people out in our community. Our rural areas still to this day rely on volunteers. So that's pretty hard to come by these days. I know if anybody here volunteers for an organization, you don't see a lot of new faces coming up to volunteer. That's a true statement for any volunteer, whether it's an ambulance service. Fire departments are the same way. If you look in the news or talk to your local communities about volunteer fire departments, volunteerism is down. That's the strain on our communities on what it takes to become an EMT or a firefighter. The hours that you have to put in are going up, and the attendance is going down. So it's not a good path that we're on. Some certification levels. So who's on the ambulance? You call 911, you expect an ambulance to arrive to your doorstep. Who here knows that there's a difference in type of service that you're going to get with an ambulance? See a couple hands. Yeah, so The three main people or certified people that are going to be on an ambulance are EMRs. So that's a first responder. That's what a lot of your local police and fire departments are. They're trained at that first responder level. 50 to 60 hours of training. This is usually a class that's done over a month, and there's no formal test for it. You just pass the class and welcome aboard. You can respond to medical emergencies now and provide care. EMTs is a little bit more strenuous. So this is going to be spanned over 3 to 4 months. You get a lot of advanced training. You get further knowledge about the anatomy and physiology, how things work, and how to correct things, certain medications that would help that they're allowed to use, stuff like that. Then you go up to paramedic or the advanced life support. So that's what the ALS stands for behind that. Paramedic is typically associated with a college degree at some level, whether it's a certification or an actual 2-year degree. You can go all the way up, and you can even get a doctorate in paramedicine. Actually, the former director, way before my time here, actually just completed his doctorate for funsies, I guess, but it's pretty cool. So it is an actual career path. EMTs, paramedics, the hours they put in, you're talking, like it says here, 12 to 1800 plus. It's more on the plus side. I think the average is about 2200 hours between classwork and then all your clinical rotations that you're required to do. A lot of these services require you to spend time in different parts of a hospital. So you're going to spend time in an OB part, and you're going to learn about childbirth and complications with childbirth, and you got to be part of some of those. Intubation, so they're going to spend time in an OR actually assisting with or providing intubation to patients and sedating them and helping with the med administration, stuff like that. And then ER clinicals. You're going to be in the ER starting IVs and getting patient assessments, and it's a lot. It's a big time commitment, especially for what you get in the end. But yes, there are significant differences. So ambulance driver, who here refers to EMS as an ambulance driver, right? We hear it all the time. I understand where it came from, because essentially EMS started out as drivers. That's you get in and let's go. You're an ambulance driver, right? We've evolved dramatically over the past few decades, and especially in the past 10 to 20 years, EMS has taken bounds and leaps ahead in the treatment that we provide to people. So we're actually pre-hospital clinicians, EMTs, paramedics. We have a lot of knowledge, and as Andy said in there, we understand what it takes to save lives. So we are paramedics, we are EMTs. Do we drive the ambulance? Absolutely we do, but that's not our primary title. And it just kind of it's a very polite dig on us, I should say. Like, it's not an insult, but it's like, well, I do more than just drive, So what makes us special? AHIMS, or Astera Health Emergency Medical Services, we are a multifaceted rural lifeline. So EMS is kind of a weird, unique little creature because we are public safety. When you call 911, we show up with an ambulance because you need medical attention, right? We're a transport service. So you get to the hospital and the doctor says, okay, you have this diagnosis. We don't have anybody here that can help you with this, but Fargo does, or St. Cloud does, Duluth. We've taken patients to Bismarck, Sioux Falls, Rochester, all those places around. So yes, we are a transport service too. Now, whether you have medications running or whatever it might be that justifies that ambulance service, we're there to provide that transport. The pre-hospital care that we have, we're very fortunate here in Astera to have full staff of paramedics. So we're very confident that when you call 911 in our area, you're going to receive an ALS ambulance, that advanced life support. So there's going to be a paramedic on scene. We have 10 full-time, soon to be 11 full-time paramedics on staff, and half of those have gone on to school above their paramedic and achieved their critical care certification as well. So that's another semester of college on top of that, more clinical hours in the ICU, stuff like that to advance their level of training as well and their knowledge on how to treat patients out in the field. Here we also are an education provider. So we do our own education in-house. We have our own EMS education department. A lot of our staff are instructors. So I think we have like 19 or 20 CPR instructors on staff. We go out to the communities. We provide support to all of our local fire departments, police departments, stuff like that for educating on that. And we host EMT classes and first responder classes right here at Astera. Community partner, so we also are contracted with the Lakes Area SWAT. We have 2 paramedics that are on with the SWAT team. They are integrated with the team. So anytime they get called out and they need medical support, we're there with them as well. And then we also have a community paramedicine program that we are part of. He's actually here today too, just supporting me, but it's a great program. They can bring a lot of the cares to your door. You know, I know he's busy all the time going out and retrieving lab draws or whatever it might be that you need that we can assist with on that CP side of things. So this is just kind of a picture. It's harder to explain, but if you go online to the state website and you look up Astera's primary service area, this is a map that you're going to show. I just put it up there to show that we cover almost the majority of Wadena County. Big section then blue, that's Otter Tail County. The little section below is Todd County. And then we have just a few sections up in Becker County as well. What they don't have on here is it's actually cut out. The southeast corner is Lakewoods area. So, but we're still roughly 800 square feet of service area that we cover. Who we are, so these are the lovely faces that you will see if you call 911 and you're in our area. Our ambulance arrives. So there's 28 of us currently, I believe, total. As you can see, we have more paramedics than we do EMTs, and that is intentional. That's Astera's dedication to providing that advanced life support 24/7. We have 2 ambulances on 24/7. So we station 1 here in Wadena. 1 is generally stationed in Sabika to kind of help cover that northern part. And like I said, we have a minimum of 1 paramedic on all the time. We each try to have at least 1 paramedic on each ambulance as well. So, like I said, 800 square miles, 24/7 ALS staffing. Population, if I calculated correctly, it's somewhere around that 20,000 mark in our total service area. So this is including cities of Wadena, Sabika, Monaga, New York Mills, Verndale, Bluffton, and then those surrounding rural areas in between. We do have a total of 4 ambulances. 3 of them are stocked, ready to go. We have what we call a backup, so we can rotate 1 out because we put a lot of miles on. And so we have the ability to call another additional crew in if it gets really busy or if we have special events to attend, stuff like that. So we can cover more of that. The QRV, our quick response vehicle, it is outfitted with ALS equipment, meaning it has the specialized cardiac monitor in it and it has all the medications and stuff that a paramedic is certified to use. In the back of it's a Tahoe SUV. So if something were to happen, which it does, if you work in public safety, you know that everything happens all at once. But when we have multiple calls, and let's say we have an ambulance in New York Mills and another one in Monaga, which happens quite regularly, and I'm doing my office duties, I can jump into this QRV and I can respond to the scene and provide that care quicker than waiting for the ambulance to come wherever it has to come from. If it's one of our neighbors that comes in and helps, or if one of our ambulances is just freeing up. So what we do, so all of our EMTs are nationally registered EMTs. These are the basic skills that they are tested out on at a national level. And it's kind of highlighted in bold on the bottom. They do not perform advanced airway interventions, IV or IO. So an IV that goes in the vein, and IO, that's an actual catheter that's drilled into your bone, or any drugs or stuff like that. So why I highlighted that is because here at Astera, our EMTs are varianced at a higher level. So they're at more an advanced EMT than what you're going to normally see in some of your smaller areas. So they can start IVs, they can start that IO, they can get access, they could administer a handful of medications as you see. So that's pretty awesome that we're able to provide that here. Paramedics, I know that's a lot. It can be a little bit overwhelming. There's a lot of stuff to look through here. This is, again, your standard, what paramedics are tested out on when they go to class and they take that National Registry exam. A lot of stuff up there, as you can see. We go above and beyond that here. We want our paramedics to be advanced paramedics. So anybody that gets hired here and is put through our training process before they're let loose to be on their own in an ambulance, they got to complete all these competencies and show us that they can understand how to take somebody on a transport ventilator, how to sedate, paralyze, and intubate. Some processes that some of you may not understand here, but some of the stuff that is well above and beyond the standard care that you might see from other just national registered paramedics. I know some of your larger services, and somebody here, if they know more about this, but AMR, like you have to have a special certification before you can even reach a point where you can intubate. You have to have years of service and special tests that you take and everything. So we do that right up front here. So all of our paramedics are trained at that higher level. Some of our fun facts, established in '88. So Tri-County Hospital actually bought this service in 1988. It was shortly after that they're like, we need to advance our care. So we want paramedics on our service. We're going to be an advanced life support service. And somewhere in the early 90s, they got that license, and they've been ALS ever since. High call volume the last few years. So that pandemic hit 2020. Ever since then, our call volume's gone up 500-ish calls per year. And we've been maintaining that 2,000 plus every year since then. So that's a lot of calls for just 2 crews to handle, especially when we're taking roughly 500 interfacility transfers a year. So we're taking patients from this hospital to other hospitals in other cities roughly 500 times a year. Because of those transfers and our large service area, we average about 54 miles per call. If you pencil that out, it's going to be about 119,880 miles per year. Fun fact, that's driving around the earth 5 times. So paramedics, they are required to complete 60 hours of continuing education every 2 years. EMTs need 40. So we're always constantly going to class, learning, and re-upping our skills. We also have a very diverse workforce. So you get into EMS, like we always joke, you don't choose EMS, EMS chooses you, kind of a thing. And it's so true. When you ask anybody at my team, like, what made you decide to get an EMS? They're going to have some wild story about, I don't know, somebody told me I was supposed to do this, and they go to a class and they get hooked into it. So this goes from anywhere from law enforcement officers, we have chefs, we have pastors, all those types of backgrounds on our team. So it's very neat to hear their stories. As I mentioned, 19 instructors. We also do our own EMT classes. You have to get another special certification through the state to do that. So we have another 9 instructors that are able to do that. Last year we served 757 students in 1 year, and that's through the American Heart Association. So excuse me. All those services on the bottom, that's who we provide medical support and education to. So you can see that it's quite substantial. And we cover distances. We actually just picked up Gray Eagle Fire Department. If you're familiar with where Gray Eagle is, that's southeast of Long Prairie. So Yep. But again, that's part of that diverse workforce. We have a staff that, they come from all over. One of my part-time paramedics, he works full-time in Fargo, and he drives down here to work with us. All right, some of our challenges. Staffing. So here at Astera, we are very fortunate with our current staffing model, allowing us to maintain that 24/7 coverage full-time. You go to any other of our surrounding services, or if you turn on the TV, you're probably going to hear about staffing shortages. And again, that comes back down to that volunteerism, but also the pay. A lot of EMT wages, they start out at $17 an hour roughly. And if you go to your local Dollar General or Walmart, you're probably going to be making $20 an hour, and you don't need experience in anything. As an EMT, you need to be nationally registered, so you have to have all those credentials in place before you can start at a service. So, why this is our financial pressures. So, when we say segmented billing, it's not just a standard bill that you get in the mail, right? Because we are healthcare providers. Now we're dealing with insurance, right? Healthcare insurance, and we all know how fun that is and how great it is when you're getting reimbursed for some of these services and everything gets picked apart. And EMS is kind of at the bottom of that list of, we're going to pay for the transport, but I don't know that we can provide any extra funds for any of the services you provide. So we have to be very careful on how we document what we do and the necessity of it. So it's very strange to me, and stepping into this managerial role, I come from a fire department as well, and does everybody pay a tax to have a fire department in their area? At some level you do, some cities don't, a lot of townships do. You have a contract agreements that get signed every year, and then on top of that, if you have a fire, you get a bill from the fire department, right? But EMS isn't like that. We don't get any money from taxpayers. I shouldn't say that. We got some grant funds just in the last couple of years, which we're very grateful for. But standard practice is some EMS agencies are allowed to tax their communities, some are not. Not that they're not allowed, it's just that they choose not to. But the funding that we're seeing is not available, and the cost of operating an ambulance service continues to shoot up tremendously. A new ambulance, when you order one, it's $300,000 minimum, and you're looking at 3 years maybe that you might see it, maybe not. We're not sure. It's going to be almost 4 years from the time we ordered our last one until we see it. So you can see that we're stacking miles up, right? Our equipment is aging, and there's just no answer to it. Like, all these larger ambulance manufacturers are in the same boat. It doesn't matter which one you go to purchase. They're expensive to make and a long waiting list to get. Wages, cost of living, I would imagine we're all well aware of those, increases recently. Wages are lacking, so the financial pressures are a real thing, and that's why you're hearing a lot of scuttlebutt, what it might be about, some services are talking about closing their doors. There are hospitals out there that are talking about closing their doors. So it is a real thing. We call it the cost of readiness. So our crews are on 24/7. They're here, they're ready to respond. They're not a volunteer service. We're not sitting at home on call, because that's kind of a thing of the past these days. We're running so many calls now that we need the crews here and available. And to keep your people here and available, you kind of have to pay them. So, I took this clip out of the state website that a lot of us providers have access to, and it's kind of busy. There's a lot of numbers up here, but the gist of it is there are more people leaving EMS than there are entering EMS. And that chart up there kind of showed that. Year after year, we're seeing people at that 2-year mark, you're seeing that people are like, this isn't for me, and I'm not recertifying. and the number of new people coming up is less than what's leaving the workforce. So our EMS agencies are getting smaller and smaller. That staffing is getting harder and harder to acquire, which again is why we're a very unique service. We have a very great culture here, and Astera does a very good job of advocating for our community to keep our ambulance service up and running at the caliber that it is. Anybody have any questions on any of this kind of so far? I was talking kind of fast and zipping through them, but.
Are all 28 of you on call at all times?
Nope. So we run shifts. So similar to like a fire department, you know, we're here. We do 12-hour shifts. We're able to put a couple together if we need to extend them out on 24 or cover other shifts. So, but yeah, we have 4 people on staff, 24/7. It's typically 2 paramedics and 2 EMTs.
So do you have any idea why you have more leaving in EMS? Is it because of wages, or is it burnout, or what?
It's all the above. Wages is a big thing. I have that chart up there that kind of showed the skill levels of paramedics versus nursing. What I failed to explain, and I should go back and show you guys, a lot of our paramedics are going to be that specialty care, the critical care paramedics, which is equivalent to a BSN for an RN. And if you want to talk wages, it's double the wage to be a RN than it is a paramedic, with essentially about the same certification. So when you can go make $60 an hour as a nurse versus $30 an hour as a paramedic, it's kind of.
Do you go to like high schools or tech schools and
Yep.
present this?
We do, yes. We recruit. Again, this is kind of and I don't know if it's unique to Astera or not, but we do a high school internship program. And so that's actually starting next week. We'll be seeing high school seniors that will be seniors this year come in, and they can ride along with us. They can do internships, and they do that throughout our entire facility here. So we also go out to the high schools and we present and recruit and show them some of the cool stuff that we can do. So.
How old do you have to be
18. I think you can test out and you can become nationally registered younger than that now. They changed that rule, but to be employed anywhere, it's kind of tough unless you're at least 18 years old. I know some volunteer services, they're able to accommodate, you know, as long as you have a driver's license, so that 16-year-old part, but yeah, so.
Do you need a special license to drive the ambulance?
You do not. You take a course, and that's usually within the department that you're hired in. Yep. Mm-hmm. It's kind of scary sometimes, especially being the person in the back when you have somebody, you know, that just got their driver's license a couple of years ago, and I've never drove anything this big, and it's snowing out now, so hang on. You know. So this is my take on what the future of EMS could look like. In the hospital, we're seeing a lot of advancements in telehealth. We already do the telestroke, so if somebody's having stroke-like symptoms, they call them up on the video screen when they're in the ER. I foresee that happening in the back of an ambulance. We already have to have internet for our other report writing and stuff like that, so why couldn't we have this same video screen up on the wall in the back of an ambulance doing the same assessment with the same neurologist that much quicker? That's just one part of it. Telehealth, like I said, it's expanding rapidly. So I foresee that in 5 to 10 years being pretty commonplace in a lot of ambulances. Our cardiac monitors already that are being produced can live stream to an ER or maybe a cath lab. So that's coming too. We pick up a patient, we're like, oh my gosh, classic signs and symptoms of a heart attack. We're putting our EKG on there, and I'm pushing the button, and it's going to call up somebody at the cath lab, and a cardiologist can lay eyes on that EKG and be like, get them here right away. And instead of stopping somewhere else, you're just going to go straight to the place that you need to be for your operation, which is really cool. You know, that's not far out at all. That's, you know, you get through the politics of it all, and that could be within a couple of years that we're doing that. So, yeah, that kind of reminds me of Emergency, again, that old show when they call Rampart, you know, and they're doing this in the 70s. Why is this taking so long for us to get, you know, do this now? But yeah, ECPR, so extracorporeal CPR. This is ECMO. Their equipment is quite a bit smaller. We have it. I know they have it in our state in flight, I do believe. So you can request a service. I just listened to a podcast recently where they're actually, this is down south, I don't remember exactly where, but they're actually implementing ECPR stations essentially, or they're going into rural hospitals that are in the middle of nowhere and there's no cath lab nearby. And they're getting funds to put these people in place, these teams that can provide that ECMO CPR, so they can actually bypass your heart while they're fixing whatever underlying issue is causing your heart not to beat correctly. And they're doing that in these small communities. So that I see as another huge advancement coming soon. Eventually, again, that could lead to pre-hospitally as well. So you train your paramedics, whoever it might be, or if you put the right people on your team, they can do it out in the field too. They can do it at home or whatever it might be, you know. So it's really cool. The future of healthcare EMS it's exciting to talk about because there's a lot of cool advancement in equipment. We just need the people to go along with it. But keep the people, we need the support of the community. So that's why we're here today. Give a little education and ask for some support. The community paramedicine program, that again, we've had it for 15 years, probably, I want to say. Yes, yeah. So the state of Minnesota was one of the very first to put this together. We were one of the very first pioneers in the state of Minnesota to implement the community paramedic program. And the capabilities of this sky's the limit when you come to this. I know, and you remember Dr. Pate, he was a great advocate for this because he had the same vision. He says, we can really do a lot with this program if we treat it right and educate the people correctly on how this is going. But the treat and release program, so getting a paramedic on scene, you're like, I don't know if I need to go to the doctor or not. Right now you call and it's like, yep, go to the doctor. We can't make that call. But down the road, can somebody show up to your house? They can assess you. They can run some tests, whatever it might be, and you can stay home if it's not that bad, you know. Or if you need an ambulance, they get you an ambulance there. There are some larger metropolis type services that are actually sending out, they call them triage paramedics. So you call 911, a paramedic in a vehicle like our Tahoe would show up to the scene and they'd be like, here's a bus ticket and you're going to go to the clinic because this doesn't justify an emergency, or it's, you know, it's bad, you need an emergency, I'm going to get the ambulance here right away. So and that's just the strain on EMS that they're seeing in the metro areas, is their call volumes are so high right now. And I don't have that study in here, but some numbers came out with one of these larger departments on like 30% of their calls were non-emergent calls that were taking ambulances out of service, and they just essentially needed a ride is what it came down to that. So, but to get to that point, we need to be able to bill correctly for the services involved, and that's going to cause a lot of I don't know what the word I'm looking for is, but we're going to need some movement at the state level and legislature to be recognized as a service that can bill for that kind of treatment. So before we get to the Lucas, I want to share the other part of Andy's story. This is one that if you're on Facebook, you probably have already seen, but I just want to share that with you. And then just warn you guys, anybody that's ever seen the Lucas out in the field, like it can be kind of cruel. It looks that way just because of the mechanical features. So if that bothers anybody, just feel free to, you know, tell us to stop or get up and go take some fresh air or something, whatever it might be. But it's just a dummy. I promise you we're not going to hurt him. So just bear with me a second here while I pull up this other story.
Who's your medical director now that Dr. Tate retired?
Rachel Rettig. Yep, she's board certified on emergency medicine.
Thinking back, like this whole thing was like a miraculous chain of events, starting with the accident itself to, to Henning being on spot, the fire department, the ambulance, to getting into, the transport, to getting here, to getting to, then I was in St. Cloud, and then from St. Cloud, I was flighted to Mayo. Like the whole thing is just a miraculous chain of events. And if one of those links breaks down, it would have made the difference. I'm sure of that. So it's just like everything just lines up the way it needed to, but there was so much work to train those people and for those people to have the ability to do what needed to be done rather.
Here at Astera Health, we are very blessed to have the hospital support on our EMS education program. We do internal education, we do external education, all those different departments that we were talking about, we've had outreach with them to do training, right? We run at least 2 EMT programs a year, multiple first responder or EMR programs, and we service all of these departments in a local and kind of regional sense with training that goes from CPR all the way through different core skills for the job. So without something like that in place, it's another thing that would collapse the system. You wouldn't have people that would be able to sustain the training requirements that are out there, because they're the same for volunteers as they are for full-time people.
So if I'm ever in an accident again, which I hope I'm not, but if I am, or that next person, when our volunteer firemen, EMS, ambulance service, first responders, when they roll up in towns like Henning or in any town around here, you need their training to kick in. And like that is as vital as anything. I can just tell, like in having conversations with them, how knowledgeable they are and how vital that training is. And because that's what's going to make the difference right there.
The time that's involved in the training that we do now is it's extensive, and you're not compensated for that as a volunteer. But it's moments like these, like the importance of being part of this picture. Like, just think if you didn't have Henning Ambulance or Henning Fire or anybody there to first respond, to get that initial patient contact and get you rolling, get you going in that direction. Like you said, Andy, did you have minutes, hours? You don't know. You just know that you felt yourself fading. So it's so important. And even how Chelsea mentions that she's just a small pebble in this big success story, but it's a very important pebble. That people don't understand that how important it is to have those services in your community.
Why is it called a Lucas?
It is named after, I believe it's a child called Lucas that went into cardiac arrest, and I don't know the entire story on that, but I do believe that's where the name came from. It was the family of this person really went after manual CPR devices, and that's kind of where this all came from. The purpose of the Lucas device is to deliver consistent quality chest compressions. So if anybody here has had to do CPR on a person before, you know how exhausting it can be. And when we test people out in CPRs, and we tell them that they have to do compressions for 2 minutes, because that's when you take a break and you recheck for a pulse, stuff like that. It's a long time. You start pumping on somebody's chest and you get tired really, really fast. Now, speaking from experience, when you're in firefighter gear and you're doing CPR on somebody, you get that much more fatigue that much quicker. So the Lucas device is one of several that are out there. There's many other devices that can do the same thing. Lucas is kind of the pioneer here, so they started it, but this device has allowed us to deliver those quality compressions and free up those hands for the paramedic, the EMT, to provide some other interventions. So if they need to help with the patient's breathing, if they need to get access so they can administer medications to help get that heart going again, now they have the ability to do that, and they don't have to worry about switching back and forth on doing chest compressions. So,
Really? First responders have?
yes, actually, thankfully in the state of Minnesota, there's been a lot of grants come out recently that have allowed these smaller departments to apply and get a Lucas. So I live in Clarissa. If you're not familiar with it, it's a very small town of 600 people. Our volunteer fire department, we run like 80 calls a year, so it's very small, not a lot. We applied for a grant and we got a Lucas last year. So if my small department can do it, there's a lot of other small departments that have these now too. So yes, it is. Even though the recent change from the American Heart Association did a study, and they said that there was no change in patient outcome whether you had the Lucas device doing CPR or just a bunch of guys doing CPR instead. We'll just leave it at that. I don't agree with that, especially in some of our rural areas where we could be doing CPR for 30 plus minutes. I've personally had to do it for almost an hour. And that's when you arrived at a hospital even. So sometimes the Lucas doesn't fit on all body shapes. So yeah. Any other questions? Otherwise we'll set it up and I'll kind of show you what exactly it does. Sure. So this yellow thing, this is just a backboard. It's going to go behind the patient. So we would have to move a person, usually if we just roll them to the side, then we can slide it under them. It allows a hard surface to be compressed against, and it also allows this to be secured to that backboard. Yeah, so this is the device. Yeah, so.
I know it looks like a midget.
Yeah, yes. Promise you it's not. Yep. So it's set up, and then it has some other straps. We would typically, on a real person, we put a strap behind the head, and then we clip it into these clips that keeps it from moving around. Yeah, and then it has these straps here for the hands too, so we can keep the arms up. Yep. So just like that, you turn it on, you push it down, it sets it, and then you press play on the button, and it is going to do that compression until we stop it or the battery goes dead, which we carry the charger, an extra battery. This is going to run a long time doing this compression. And it's going to be the same every time, and it's not going to get tired.
You know, you do the same speed, or you just slow it down or speed it up?
Same speed. So this is going to do that 120 compressions per minute is what they recommend.
Can you use the same one on an adult as a child?
So depending on the size of the child, they may not use this device. So, yep.
Is there kind of a weight limit? I mean, how big of a person?
Not a weight limit, just a body size. So sometimes, like I said, there's some larger people that, as long as you can click this into the backboard, you can use it, essentially. So there are other devices out there. I actually just seen one last week. They brought and showed me that it's a band that actually has a backboard too, but the band goes over it, so it can fit a lot larger people and a lot smaller people than what a Lucas or a device with this arm can do. So.
Well, you mentioned that if you're doing it manually, you do it for 2 minutes and then check for a pulse. Do you do that for just 2
Yep, so you can. So there's two buttons up here. One is it's going to go nonstop. The other one is 30 compressions to 2 breaths, but at any point, 2 minutes, we're going to stop, and it's going to check. The way we run cardiac arrest with paramedics on scene, we're going to do compressions constantly, and we're not even going to stop until we hit that pulse check mark, and then we're going to do it because we actually have our monitor on there, and we can see underlying rhythms through this as well. So if we see changes or something, we can stop it. Yeah, so we have one on every ambulance. The ER has one here, so it's, like I said, and there's a lot of smaller departments that are getting them now too. So roughly $20,000. Yep.
What would be the advantage of having a lupus versus an AED?
You want both. AED would probably be priority because you can do compressions, you cannot interpret a rhythm and shock it. So AED is definitely priority. Those are a lot cheaper to purchase, and there's a lot of grant funds for them too. Science has shown that early defibrillation saves lives. So if somebody goes down and you can get an AED on them, the quicker you can get an AED on them, their survival rate skyrockets. Because that heart is still, whether it's quivering or beating too fast, it's going to detect which rhythm it is, and it's going to administer that shock.
You know, when you put an AED, let's say in a church or school, they have them in the gyms, but how do you know exactly, I mean, they always in the same place, like the front of the church, the back of the church, and the gym? You know what I mean? Because if you have a bunch of people running around and you say, go get me an AED, I don't know where they are.
Yes.
You know what I mean?
Yeah, there's no rhyme or reason to it. They're going to put it where it's easily accessible, and hopefully they have some signage up somewhere, or somebody in the building knows that that's where the AED is. If somebody's called, they're going to send somebody that direction or go grab it.
In most of the schools, is it always the gym though? Do they have more than one?
They probably have more than one. Yep. Mm-hmm.
And all personnel has been trained in how to use it.
Yeah, excellent. Mm-hmm. And if you know anybody in the community that has an AED and they're afraid to use it, by all means, reach out to me. I've gone out in the community before and just walked people through on what it does, and they're very straightforward and easy because you turn it on and it's going to tell you exactly what to do, which is great. But
I work for a school, so we have multiple AEDs located around the building, but we also have a portable one. So like when we have sports going on out in the sports complex, the AED is out there. And they're all coaches are trained to use it over there.
And our 3 athletic trainers here also have portable AEDs as well.
mm-hmm. Good questions.
Does he have one in his package, a medical guy that comes to our games? Comes from here.
Yep. Yep.
He has one in
Yep.
his
He's the, yep.
I
Mm-hmm.
didn't know that. Well, yeah.
You bet. Yep.
So I know that you said that it doesn't make a difference, using the Lucas versus regular chest compressions, but does it change? I mean, I just remember breaking ribs doing CPR. Is that just as much, does it happen just as much with the Lucas?
Yes. Yep, it does. Mm-hmm. So I don't remember the exact pounds of pressure that this administers, but it is enough to fracture ribs. But if you're doing manual compression, you're probably going to do that as well. Yes. Any other questions? Well, I apologize. I went way longer than what we had scheduled. So, very good. Good.
I hear a lot of people say, well, I'm not calling the ambulance because I don't know if I need to go in and expense, but you had up there, right? You do not transport, but if you have to do a thorough assessment, is there a charge for that or only to transport?
Currently, we do not charge for that. I can't say what the future holds because as we look at trying to keep our service up and running, it might be something that we look at starting to charge for, but currently, if you're unsure if you need an ambulance or not, if we show up, we're going to check your vitals, we'll check your blood sugar, whatever it might be. And if everything's fine and you don't want to go, there's no charge for that as of right now.
Can you make a call from the scene? You know, you see sometimes the helicopters go to a site. Do you make that call and you can call them and send them?
Yep. Mm-hmm. Mm-hmm.
Do you have anything coming up like specifically fundraiser specifically for EMS like the ambulance? Do you have something else out there?
Not right now. The ambulance poll was kind of the last one that we just did, but yeah.
It's actually out on the foundation website to be able to donate.
Okay, that's perfect. Yep. So there is a way to donate to it. Biggest thing we can do is educate others, educate your community, and advocate for EMS at that governmental level. So local government, state government, federal. Get those laws changed or in motion to allow EMS to stay, you know, a sustainable service. So like one thing I didn't mention is if you look up essential public safety services, EMS is not one of them in the state of Minnesota. I believe the last I looked up, I believe there's 22 states in our country that recognize EMS as an essential service.
How can we get that changed?
Reach out to your representatives, your state senators, representatives, legislators, stuff like that. People that can make that change at that state level. The Minnesota Ambulance Association has been a huge advocate and a big push as to why we got some of the grant money that came out last year and again this year to kind of help support some of these agencies and keeping them afloat by paying their people and helping them get that equipment that they need. But to sustain it, we need some laws changed.
So Kim, like we did donate it to the cancer center, you know, with tax exempt stuff. Can you do the same thing for that? How, do you just do Astera Health and you just earmark it for that?
Correct.
Okay.
Absolutely. Straight to the foundation and then.
Okay, so it's same as the cancer center, but then you just say, I want this to go to EMS.
Correct.
Okay.
Is that mainly for equipment, the new ambulances and stuff, or?
It's everything.
Upper.
What is your loss per year?
Roughly 1.5 million.
Yes.
Mm-hmm.
I think a lot of people realize how lucky you are to have,
Correct.
you know, such a good EMS.
Mm-hmm. The rarity it is to have advanced life support in a rural setting. That's another thing that's another number I didn't put up there, but I think there's 252 or something like that registered ambulance services in the state of Minnesota. Of that, only 70 of them are advanced life support agencies. And the majority of those are going to be your metropolitan services, your fire department, your big full-time fire departments that have them, like Virginia, that's way up north. Hibbing, I think, is another one that's like that. And then, of course, a lot of your metro areas. They run paramedics on with their crews and ambulance service as well. But that's very rare to have a service in an area like this that's full-time ALS. A lot of them are part-time ALS or just BLS.
So you have another ambulance on order, you said, or?
Technically, we have 2 on order, yes. Mm-hmm. Yep. Fingers crossed. Hopefully next year we'll get one, and hopefully the year after that we'll get the other one, but it's been a long, drawn-out process. One of our ambulances just had a catastrophic mechanical failure, because it had almost 300,000 miles on it. So we traded it in and we bought a used one, because that was something they had available, and it was something that we could fill in the gap, so until we get our other ones. Mm-hmm.
Does Clarissa have their own ambulance?
Clarissa does not. No, they're only a fire department. They're serviced by Browerville Ambulance, so in Bertha. Yep.
So we are fortunate though that we have so many of the rural communities do have volunteer ambulance services. That's a
100%. 100%.
And that's a shout out to the communities for promoting it.
Yes. Yes. Mm-hmm. Yep. As I said, it's hard. Like there's a lot of people leaving the volunteer services too, because as we mentioned in them videos, it is the same amount of certification, the time that it takes for to keep your certifications up is the same for us full-time people as it is volunteer people. And volunteers, generally you pick that up as something to do on the side. And when you have to do all them hours, and now you're only have a staff of half a dozen people to staff an ambulance 24/7. Like now you're taking all this call time and you have no family life, and it's burnout in the volunteer world is huge right now, and it's very unfortunate, but it's a reality we live in.
All right, well, thanks, Chad.
Absolutely, thank you.